This is our patient approach lesson, recorded today on March 20th of 2020, right in the middle of the COVID-19 event. It's in effect from now until probably forever. We need to approach all patients in all situations in a standardized way. And while this was triggered by the COVID-19 event, it's also applicable to all operations on all calls. And in some of those cases, we may encounter an Ebola patient or some other significant pathogen. We'll need to add some things to the end of this process or additional things for those special cases, but this is the core basic process. It's consistent with CDC guidelines approved by the fire chief, medical director, and incorporated into applicable policies. The big idea here is that we work in a dangerous business. There's numerous risks, and we mitigate those risks with knowledge, training to apply that knowledge, and to incorporate protective equipment and protective practices. So when we approach patients, we're going to approach all patients in a standardized way. Some of those may cause us to have a high index of suspicion that there's infectious disease, others will not, but we're approaching all patients in a standardized way. And this will talk about the appropriate PPE requirements so that we can prevent exposure while we provide the patient assessment and treatment that our patients need. When we talk about scene safety, there's multiple potential hazards. There can be animals present or people that are going to try to hurt us. There can be traffic, things we can trip on, things that can cut us. Things can catch on fire, explode, things collapse. There can be unsafe atmospheres. And there's also infectious disease. It's just one of numerous scene hazards that we all attempt to mitigate these, again, with knowledge and with training and with PPE. So let's talk about zones. And so on EMS calls, we're going to divide the zone into cold, warm, and hot, just like in a hazmat situation. And the definition of the cold zone is the exterior of the structure or the compartment where the patient's in. So when we think about a motor vehicle crash, the compartment would be the vehicle in that case. So these zones extend to all types of EMS events. There's the warm zone. That's typically the interior of the structure up until you get right next to the patient. And then there's the hot zone, which really is 6 feet, maybe 10 feet from the patient. 6 feet is good and safe unless they're violently coughing, sneezing, vomiting, in which case an additional 3 or 4 feet would make some difference. And then there's PPE levels that are tied to those zones. So how do you decide what PPE is appropriate? You decide what zone you're in, and that tells you. In the cold zone, we're just wearing street clothes, whatever we normally wear in our daily activities and daily job. And the cold zone is where additional PPE is donned. The minimum to approach an EMS event is going to be level D, and we'll talk about what that exactly is here in a second. And then when you're in the hot zone, you may need level D plus droplet precautions. It may be that level D is just fine. So you have to decide at the warm zone, hot zone interface, stop there for a second, assess the situation, and decide if you need to add those droplet precautions, which would be an N95 mask and goggles, added to what is already your level D, which includes long sleeves, long pants, closed-toed shoes, and gloves. And then decon occurs technically at the warm-cold zone interface, and the person deconning equipment needs to be in level D. The person typically deconning our personnel would not need to be in that level D. And we'll discuss that in detail as we get through here. So again, PPE levels. Level D is your typical uniform, which is no level of PPE. And then you add on to that to make sure that your arms are covered, your legs are covered, your feet are covered, and that you have gloves on. So we're talking here, typically for us, our wildland jacket, which has long sleeves, and some medical gloves. Then if you need to add droplet precautions, you use all of that, plus you add an N95 and goggles or protective eyewear. So how are our personnel going to handle things? Well, we're going to talk about 3 roles. There's contact, there's cover, and there's support. And so it's important that we check each other, a buddy check of the PPE. So contact's going to check with cover, and contact checks cover, cover checks contact. This is the same thing we do on structure fires. Right before you make entry, take a look at your partner that you're going in with. Make sure you're covered and things are on like they're supposed to be. Then as we move in toward the patient and the contact person makes actual patient contact, cover is going to announce that on the radio. And it's a simple transmission that involves we have patient contact. Contact's going to make that approach and initial assessment from the hot-warm zone border, decide if additional PPE is needed. In other words, do we need to go from level D to level D plus droplet precautions where we add the N95 and add the protective eyewear. Cover's going to remain in the warm zone in visual contact with the contact person. Visual contact, preferably also verbal contact. And then additional support personnel will remain in the cold zone. And so they will typically have appropriate PPE to enter the warm zone. So they'll have level D on and ready to go, but they will not enter until they're asked to move forward. So we're going to do patient contact with one person who is covered by a second person still in the warm zone, and both of those are at level D unless the contact person assesses the need to go up a level and add the droplet precautions. And we're kind of in a stack sort of format to where as one moves up, another one backfills behind them. When you need more than one care provider in the hot zone, cover is the next person in. They're in essence on deck, ready to rapidly intervene. And so the cover person is going to engage in the hot zone with the appropriate PPE. Again, that's determined by the contact person's assessment at the hot-warm border. Then additional support personnel will move up to backfill so that we still have someone in the cover position, and if we have to engage more than one person in the hot zone. And then if you think all the way to the extreme to a cardiac arrest, where we would need to engage multiple personnel in the hot zone, we still need someone in that cover position in order to provide that role. Equipment should stay in the warm zone whenever possible, and then would be passed into the contact person who's in the hot zone, passed into that contact person by the cover person. Items in the hot zone should stay there until we can decon them, and perhaps the ambulance crew, which will follow behind us, will be able to utilize some of that equipment without adding additional equipment of theirs into the hot zone. We want to try to also make sure that portable radios stay in the warm zone, and I'll talk about that some more in just a little bit. But at any rate, the contact person has moved into position where they are 6 to 10 feet away from the patient. They're still they're at the hot-warm border, and they're going to ask some questions to assess the patient and therefore the need for additional PPE. So one of the first questions you could ask, particularly in infectious disease situations, is do you have a cough? And some patients have a cough every day. Chronic lung patients have a cough every day, but this is a new cough or a change in their existing cough. Another great question to ask is, do you have any body aches, or do you think you have a fever or chills? And we don't need them to have actually measured their fever. If they just feel like they have a fever, we'll go with that. And remember, these are or questions. A person with a cough but without a fever could still have an infectious disease. And the same with that person that has a fever or chills or body aches but doesn't have a cough. You don't have to have all of these things. You really just kind of have to have one. We would also ask if the patients have any vomiting or diarrhea, because many causes of vomiting, not all, but many causes of vomiting and diarrhea are infectious disease related. And these can be simple diseases, or they can be things that are quite serious. So we're not able to identify the infectious disease process, just that there is one present. Then we ask, have you been exposed or had contact with anybody that we know has an infectious disease? And that would include questions about travel, if you've traveled to an area of known infectious disease. So here's your first decision points. You've asked some questions, you've made an assessment, and I need to figure out now if there's an infectious disease present so I know whether to add droplet precautions to my level D, or if I can proceed in to the hot zone still in level D. If the answer is yes to that, we're going to announce via radio, have the cover person who has the radio announce an infectious disease alert. And then we need to make sure that all personnel on the scene are aware of that. Again, that's going to be the cover person's role. And then we're going to add droplet precautions for contact, and cover's going to make sure that they are ready to don that equipment quickly and engage in the hot zone if needed. Then you come to your second decision point, and this is a change in our operations. We need to do a risk-benefit analysis here. Make a decision. Are there treatments that we need to do urgently? Is there a further assessment that we would need to drive treatments? And so a classic example there will be a pulse oximetry reading. Do we need to assess the person's oxygen saturation in order to decide if oxygen as a treatment is necessary? And so if there is something that we need to do, either as an immediate treatment or an assessment that might drive an urgent treatment, then we should engage with the patient and enlist additional support if needed. But if there is nothing additional for us to know, if the patient does not clearly need us to assess them, if they're not short of breath, if they don't have abnormal skin condition, if they don't appear from where we are at the safe place, at the hot-warm border, if they don't appear to have interventions that are needed, then there really isn't anything that we have to offer them, and the additional risk of being closer to them is not counteracted by any potential benefit for them. So that's a fairly large change in our operations. I want to make sure everybody is clear and has thought that through. And so we're going to show you a scenario that we videotaped. We were able to use someone's house and got some help to try to illustrate all this in a little bit better and richer, deeper way than just listening to somebody talk. So we're going to look at scenario 1, and then we're going to talk about key points from it afterwards. Hi.
Hello.
How you doing?
I'm good. I'm good.
Are you sick?
No, I'm not. That's much as my husband.
Okay.
Yeah.
Where is he?
He's in the back bedroom. I can take you there.
Has he got a fever or anything?
No fever. He just really has a hard time breathing.
Okay. Have you guys been anywhere traveling?
No, we haven't traveled. Haven't been anywhere.
Okay.
Just regular work stuff.
Hi.
Hey.
How are you? A little short of breath?
Yeah.
Okay. You have a fever?
No.
Vomiting?
No.
Diarrhea?
No.
Coughing or anything? Okay. You haven't been near any infected people that you know of, or any travel area, anything like that? Okay. Well, let me check your oxygen levels here real quick with this pulse oximeter. I'm just going to put this on your finger. You look like you're breathing pretty fast to me. So let's work on slowing your breathing down a little bit. And we'll see what that reads here right quick. So see, it's reading 99%, so that's almost perfect. Okay. So I just want to reassure you that things are okay. Okay. And I'm going to ask a few more questions. We'll let the ambulance arrive and do some more evaluation. But you look really good right now, and I don't think you need much oxygen. Okay.
Okay.
Do you have any lung disease or anything?
No.
Any heart failure?
No.
Haven't had a cough or a fever?
Medic unit.
I think that's the ambulance right there. So I'm just going to give them a quick handoff of information.
Okay.
Okay. What's your first name, sir?
Chuck.
And how old are you?
59.
Okay. So this is Chuck. He's 59. Doesn't have a fever, cough, vomiting, diarrhea, anything like that. Hasn't traveled. A little short of breath. Looks like he's hyperventilating. His O2 sat's 98% on room air. And I haven't done any further evaluation or anything.
All right.
So he's all yours.
Sounds good.
Okay. So the key points in scenario 1 is that the family member that met us at the door was assessed to be at very low risk. Are you sick? She said, no, not sick. Patient back there, he's sick. There weren't any other animals or any other threats that were obvious, and so we proceeded to a point 6 to 10 feet away from the patient and ask some questions and assess that patient to be at very low risk for infectious disease. And so level D was still an adequate level of PPE. We did not need to add the droplets in order to engage with him, measure his pulse oximetry, step back, ask some more questions. And as it turned out, his pulse ox was fine. He didn't need any further treatments. So there really wasn't any reason for us to continue to be engaged in a close manner in that hot zone. And so we stepped back, waited for the ambulance crew, gave them a handoff, reminded them that we were there to help, and then we disengaged back further into the warm zone. The hot zone was safe enough at level D to do some additional assessment And we could have done treatment without the addition of droplet precautions. So then now we're going to watch scenario 2, a little bit different, a little bit deeper in terms of things that we need to think about, and we'll discuss those key points after you watch scenario 2. Hello?
Hello. Come on in. Come on in. It's my
How are you?
husband.
Are you sick?
No, I'm not sick. Just
Okay.
My husband is sick.
Okay. Has he got a fever or anything?
Yeah, he's got a fever. He's coughing and just not feeling really good. He has some trouble
You
breathing
guys been
too.
in contact with somebody that's infected or traveled or anything?
Yeah, we've been traveling.
Really?
Yeah, we just got off the airplane.
Okay,
Yeah, like
so
here
I'm
last-
going to put on a couple extra items of protective
Okay.
equipment, and then we're going to
Okay.
come in there.
Okay.
So hang on just a second.
But I'm not sick. It's just my husband.
I know, but
Okay.
I apologize. We just need to be super safe here.
Okay.
So give me just a
That's
second.
fine.
All right, so I'm going to go in with her,
Okay.
and you're going to come in with me, right?
You got it. I'll stay in kind of
Stay,
the hot zone if I can. How about you let me take the rest of the...
Yeah, I want to leave all the stuff with you.
Okay.
I'm just going to go see what we're doing here.
Okay.
Okay, I'm sorry about
Okay.
that.
No, that's fine.
Take me back to where he is,
Okay.
and you come with me, please.
Okay. Well, he's back here.
Okay, so what's been going on with him?
Well, he's just been short. He's really short of breath, and he's got a fever. I mean, that.
You guys have any animals, any dogs or anything?
Yeah, but I put the dog up. He's good.
So he's
good.
contained?
Yeah, he's
Okay.
contained.
Hi,
But you know, that's Chuck.
how you doing? You look pretty short of breath there. Would you just kind of hang out over there? You coughing anything up?
No.
Okay, you look pretty pale and pretty sweaty. Let me get a couple pieces of equipment. I'll be right back. Okay? So I'm going to need pulse ox
Full socks,
and
mask,
we'll probably need a patient mask for him.
patient mask.
Okay? Sir, I'm going to put this on your finger, and then I'm going to help you put this mask on you.
Oh, second.
Uh-oh. Okay. So, helper, would you bring a O2 tank and a non-rebreather and come on back here with me?
O2 tank non-rebreather.
That's okay.
Can you get me an O2 tank non-rebreather?
Alright, your oxygen's kind of low here. So, I'm going to put an oxygen mask on you, and then I'll put this mask over the top of it. Okay? So let me just put this on you right quick. Sorry. Well, just to protect you and me both. I know it's uncomfortable, but...
Hey, Brian, I'm going to alert joint communications.
Yes, this is an infectious disease alert, please. And then stage everybody else at the front booth.
Okay. Boone County Suncrest Command. Boone County, can you be notified of an infectious disease alert, please?
This is just precautionary, but his oxygen levels are kind of low. And I'm going to get a mask for you here in just a second as well. Once I get him going. Is that alright? You wear a mask for me?
Yeah, that's fine.
I know, this
But
is
I'm not
kind of...
sick.
I know.
Yeah.
Just uncomfortable, I understand, but we're just being extra careful. Hey, partner,
Yes, sir.
need another patient mask if you can. For,
Excuse me, another
for this
patient mask.
lady, you can come in.
Ma'am, we're just going to head
Yeah,
just look,
okay.
just look it
Okay.
over your ears and make sure
Okay.
you just kind of cover your nose as well for us, okay?
Okay.
Alright, so I'm going to put this down
Yep, just to protect all of us. Make sure you can see.
Okay.
Okay.
and get this back up over the top of it. Best I can. I know, I'm very sorry. Okay, and I'm going to check your blood pressure.
Blood pressure.
And listen to your lungs here right quick.
You got it. Blood pressure.
And then when the ambulance crew gets here, I'll give them a handoff and we'll get you going. How long you been sick? Okay. Getting any better or getting worse? Okay. So, are you vomiting or having diarrhea? Okay. Yeah, I saw you getting nauseated there a minute ago. I wasn't sure if anything was coming up still or not. Okay.
Ambulance!
Okay, that sounds like the ambulance crew. They're here.
Hey, is it safe for us to come back?
Yeah, come on back, but you'll need masks.
All right, we're masking up.
Mask and goggles.
Hey, Bryant, what you got?
Sir, what's your name?
Chuck.
How old are you, sir?
59.
So this is Chuck. He's 59. Pulse ox was in the 80s. Put him on a non-rebreather. Have the mask over the top. Fever. Short of breath, getting worse over the last 2 or 3 days.
Right.
I was just getting ready to get a blood pressure, so I'll leave this stuff for you.
Absolutely.
I'm going to step out and let you guys all come in, and then we'll help you with whatever you need. So key points from scenario 2. The family met us at the door, and she was emphasizing that she wasn't sick, but she was potentially infected. She'd been with the patient for a significant amount of time. They had been traveling. So we declared the entire house as a hot zone. Cover person announced patient contact. And we checked on that animal who was contained, which you probably heard a couple of times throughout the video. No other threats were obvious. And then we assessed the patient, and the patient was clearly at risk for having an infectious disease. So we transmitted that via radio, an infectious disease alert. It at least provides additional information to others that are listening in. We made sure everybody on the scene was aware that we are now doing an infectious disease alert, which means the hot zone is going to be level D plus droplets. We put masks on the patient and on the family. We're in essence treating the second family member, or the family member, as a second patient without any need for treatment. The patient clearly needed non-rebreather oxygen, and so we placed a non-rebreather mask on the patient, and then the patient mask we placed over the oxygen mask in order to knock down any droplets or aerosol that would be exhaled from that non-rebreather. We did full vital signs, or we're working on full vital signs. We needed to do a more focused exam, lung sounds, and all that was going to happen, but then the ambulance crew arrived. So at that point, we stopped and gave them a handoff, and again reminded them that we were leaving our equipment and we were going to step back, but we were there and continually ready to help. It is possible that in a more serious patient, had this patient needed ventilation or he'd been in cardiac arrest, that we would have needed to engage several people in the hot zone in order to provide that treatment. And we want to point out that airway and ventilation treatments are higher risk events. We're creating droplets, we're creating aerosol, and so we have HEPA filters now for our bag valve mask. They're very simple to use, disposable, one-time use, located with the adult bag valve mask. And you simply place those between the bag valve mask and the airway. And they only fit one way. You can't mess it up. You can't get it backwards. They only fit one way, but they will fit iGels, Kings, combi tubes, pocket masks. They'll fit anything and allow you to ventilate with a way to filter that exhaled air. And then, obviously, we need to be in level D plus droplet anytime there's airway and ventilation care going on. So that would be a patient in cardiac arrest, a patient in respiratory arrest, a patient who needs us to assist ventilations. It wouldn't have to necessarily have been a call that had anything to do or any hint of or any involvement with infectious disease. We may not know. Consider the patient who is overdosed on opiates or opioids and is breathing 2 or 3 times a minute, and we need to ventilate them. We're going to need to engage in that rapidly, and we may not be able to adequately assess our risk, so we just go to level D plus droplet, and then we're covered for both droplet and aerosol. Patient handoff reminder, we want to make these concise. We want to make these brief. We want to include an introduction whenever possible. You saw that in the video. And then, so this is so-and-so. He's this age. It's nice if you know the name of the ambulance crew. You can make a 2-way introduction, but the introduction is quick and at the start. Then we give a brief, concise history of what matters. Not every single thing that we might have learned, but packaged up bullet points. Here's what matters. Here's what we found on assessment. And then again, our step back and our offer of assistance. Once the patient care event is over and we've assisted to the level that we've been requested, then we're going to do our doffing and our decon process. And we're going to provide a checklist for this because it is important that we do this right. If we're going to go to the trouble of protecting ourselves correctly, then we should also continue that protection through the doffing process and do a good decon. So the first step is a Lysol spray, and Lysol spray kills everything if you'll let it dwell for 3 minutes. So we're going to start that 3-minute clock, spray the clothing, spray the soles of the shoes, and then the person being deconned removes their gloves, sanitizes their hands. The person doing the decon doesn't need gloves, doesn't even need any part of the level D. In the video, we showed that because the person doing the decon had been additional support and was at the door ready to engage and just left his wildland jacket in place. So Lysol spray, start the 3-minute dwell, remove your gloves, sanitize your bare hands, don some new gloves. A little reminder, let your hands dry. As you saw, we struggled to get that new pair of gloves on a bit. And then with gloved hands now, remove your goggles and then sanitize the gloved hands. Then take sanitized gloved hands, remove your N95. And we're not reusing N95s at this point. In the case of an extreme shortage, there may be a process where we have to go to that. But at this point, they are disposable. Then remove your gloves, sanitize your hands, and remember to stay there for the rest of that 3-minute dwell time. I think we were probably around the 2-minute, maybe a little over 2-minute mark at that point. So we just needed to stand around for an additional minute or so. And then that would be the conclusion of the doffing and decon process. So here is a video of that, and then we'll talk about some other stuff after you watch that.
Chief, can we get the trash bag for all of our equipment to decon? Equipment. All right, go. Come on out.
All right, where are we doing decon?
Right over here in the jar.
Okay. All right, spritz me.
All right, left foot, right foot. Okay.
All right, gloves in the bag. Okay. Hand wash. Okay. New gloves.
Just your size, too.
Okay. Goggles.
Yep.
In the bag.
In the gear bag, equipment bag.
Okay. Another shot. All right. Now mask. I can't find the strap. Find the lower strap. There. That's it. In there. Now gloves off. Now game over. So again, key points on the decon, as I said, the PPE at level D for the decon person is not required. For equipment, it is. So you might as well take that into account if you're going to do equipment decon at the scene. But technically, the person doing the decon is just fine in street clothes. We try to keep portable radios out of the hot zone because they need special decon, and you really want your portable to be ready to go when you leave the scene. You'd have to take it back to the station. So do the very best you can to keep portables out of the hot zone. Kind of hard to remember, particularly if you're going in initially by yourself or depending on who ends up being contact. So try to remember that. Let's try to keep portables out of the hot zone. Keep portables in the warm zone. The decon person needs the PPE module out of an EMS pack in order to get the trash bag or bags, additional sets of gloves, and that Lysol spray. And if you're very concerned that your wildland coat, your job shirt, your bunker pants, your regular pants, whatever you had on, if you're concerned that your clothing was grossly contaminated, then we'll need to do, in addition to Lysol spray, which should kill all those contaminants, you may be interested in laundering those. And so if there's ways to manage that at the scene, you should work that out. Lysol will do its job, but if you're really have a lot of gross contaminants, you may want to launder that job shirt afterwards or that wildland coat. Deconning of equipment, we're going to isolate that from the clean equipment. So we did not put blood pressure cuff and scope and pulse ox. We didn't put those back in the red bag. We put them in a separate trash bag. So we kept them with the patient, got us a trash bag out of the PPE module, put those things in there, and then we used someone in level D to decon that equipment. It's done with Clorox wipes for grossly contaminated things, Lysol spray with a 3-minute dwell for everything else. Got to let it air dry. It's not okay just to spray it and then stick it back in the bag. So we're going to be there for a few minutes after these calls. And again, keep those portable radios out of that hot zone because then you've got to go through a more detailed process there. So that's the decon of equipment. All right, so I just want to wrap this up. In conclusion, we want you to document all personnel who operate in the hot zone, and you document that in both your incident report that you write on the call, and we want you to notify the duty chief when we put people in the hot zone. And then we want to also remind you the definition of an exposure. If you have properly worn PPE, which you decided what to wear based on the assessment that you made, it was checked with your buddy before you went in, there were no breaches during the interaction, your gloves didn't rip, your mask didn't come off, your goggles didn't come off. If you had properly worn PPE without a breach, you did not get an exposure. Anyway, contact with the duty chief to talk about these things and document all this. And this is how we're going to keep ourselves safe. This is how we're going to mitigate the dangers that we face on medical calls, just like we do on fire calls. We're going to use knowledge. We're going to use training to apply that knowledge. We're going to use equipment and safe practices. And we're going to keep ourselves safe so we can keep delivering the patient care that our patients need. Thanks for listening.